After this very nice presentation, we go to the second presentation, and that will be a dual presentation by two physiotherapists from Milan. And these are Elena Compalati and Rosario Di Marco.
Hello, good morning, everyone. Thank you for inviting us. It's a pleasure to be here. So, the title of our study is Impact of Supplementary Air Stacking on the Effect of Inspiratory Muscle Training in Patients with Late Onset Pompe Disease. These are preliminary results from a multicenter crossover randomized trial. So, in literature, there are a few studies available on this topic. Most of them report a general improvement, as you may see, a general improvement in respiratory muscle strength tests, especially maximal inspiratory pressure, the so-called MIP, which typically represents the main outcome measure, without no improvement on FVC, forced vital capacity, or quality of life. These studies show some methodological limitations, mostly related to the device used for inspiratory muscle training. The so-called threshold devices. With compliance with threshold devices is often low in neuromuscular patients because the constant load on respiratory muscles can lead to early onset of discomfort and respiratory fatigue. I'm sorry. Okay. Another important limitation is that, as you can see, the training load is set at the beginning of the studies and stays always the same. While in these two studies, we start having a progression. So we see that the training load is set at the beginning. We have the 30% of MIP measured at baseline and increased according to Bohr score. So to patient tolerance. So these are the studies we took inspiration from for our project. So now let's dive right into our study. We already know this is a randomized, controlled, multicenter study involving patients from 3 referral centers in Italy. Milan, one in Trieste, and one in Palermo. Among the inclusion criteria, patients with late onset Pompe disease undergoing enzyme replacement therapy for at least 1 year, 12 months were included. And starting from this first measure, we included the patients with a forced vital capacity over 80%, but with a postural drop in forced vital capacity from sitting position to supine position over 25%, or patients with an FVC under 80%. Non-walking patients were not excluded, as long as they did not have significant upper limb limitations and could carry out on an upper limb aerobic training program. So they were randomly assigned into Group A and Group B through a computerized sequence allocation. So, patients were evaluated at baseline at the referral center in Italy, Milan, Trieste, Palermo, and performed the program at home for 6 months. Some are still undergoing treatment. These are preliminary results. So at every time point, at the end of each phase, they were re-evaluated at the referral center with the following assessment. So pulmonary function test, blood gas analysis, maximal inspiratory pressure and maximal expiratory pressure, peak cough flow, maximal inspiratory capacity, 6-minute walking test, and 6 minutes peg ring board for non-walking patients, and of course quality of life questionnaires. So today we are only presenting the first 3 months data, but this is the full schedule of our study. So patients were supervised at home, but by specialized respiratory physiotherapists with home visits and reinforcement phone video calls. So, the first month focused solely on aerobic training, followed by 2 months of inspiratory muscle training, a fourth washout month of only aerobic training, and another 2 months of inspiratory muscle training with patients switching treatment from Group A to Group B. So, the type of intervention includes inspiratory muscle training with power breath, taper flow resistive loading, KH2P, integrated with air stacking maneuvers, along with personalized aerobic training programs for both walking and non-walking patients. We choose variable load devices because, as I already said, compliance with threshold devices may often be low in patients with late onset Pompe disease because the constant load on respiratory muscle can lead to early onset of discomfort and respiratory fatigue. In recent years, variable load devices have become available, allowing the adjustment of the load during treatment, during breathing, and thus working at higher volumes and preventing fatigue. Another important limitation of threshold devices is the inability to monitor respiratory functional data and so patient adherence to treatment, while in contrast with variable load devices, we can monitor respiratory functional data because they record working sessions, improving what is the patient adherence to treatment. So, another important key point, new key point compared to existing literature in our study is the use of air stacking maneuvers. Air stacking involves staking air in the respiratory tract using an ambu bag. Their purpose is to reduce the respiratory system elastic resistance during expiration, which is typically increased in late onset Pompe patients, mostly due to smooth muscle alterations in bronchial walls or inadequate expansion because due to muscle weakness. So from now on, my colleague, Dr. Elena Compalati, is taking over the presentation.
Thank you, Rosario. Good afternoon, everyone. Okay, so as Rosario said, patients were randomized into our 2 intervention groups. Group A underwent a double intervention represented by IMT, so inspiratory muscle training, and air stacking, while Group B did inspiratory muscle training alone. Both groups regarding IMT started with a load set at 30% of MIP measured at baseline, with the idea of a progression through time based on patient tolerance and also patient symptoms measured with the Borg scale. Regarding the air stacking training, patient did 5 sessions of 5 repetitions, and each repetition contained all the insufflation that the patient could intake. And as with the IMT, the same goes with the air stacking, meaning that we wanted patient to increase the number of insufflation that they could receive. And as we have already said, the patient went transversally a personalized aerobic training program. Also, patients were asked at the beginning of every week to record and measure their own vital capacity with the device and to write down the measurement into a diary that we gave them at the beginning of the study. Okay.
Right.
So, okay, there's a little confusion here. We asked patients, so in general, this is, okay, just follow the video for now. It's simple. It's simple. Okay. Okay. So, as you can see, the respiratory therapist trained the patient to realize the correct procedure, doing a slow exhalation followed by a deep, fast, so we can also say an explosive inhalation up to total lung capacity. And every session is composed by 30 breaths divided into 5 groups. So every 5 repetitions, patient undertake a pause. they rest, and then they start it again, up to 30 breaths. And as you can hear, the device gives a beep near the residual volume because it follows the patient, and when the patient has exhaled up to the residual volume, with the beep, he can inhale up to total lung capacity. So there's a useful feedback given by the device itself. Going on, the device, as Rosario said, gave patient and also the therapist the possibility to download the data. Okay, no. How do I get back? It's missing a thing. Doesn't matter. To download the data that is reported as load expressed in pressure, so water centimeters, in volumes that is expressed in liters, in energy expressed in joules or joules, and in power expressed in watt. So both patient and the respective respiratory therapist could download this data, write them down into the diaries, and we were able to monitor through the time all these progression. So, so far we have a sample of 14 patients. 6 of them are in group A, 60% of them are males, and the mean age is 60 years. Group B is composed by 8 people, 38% of them is represented by males, and the mean age is 46 years old. Diving into the results, here you can see a table that contains some of our outcome measures, and we reported the two groups, so group IMT and the double intervention group, and measurements results are expressed as differences for intra-group differences and for between group differences. We have already achieved some statistically significant differences, and you can see that for MIP, we have intra-group differences, but not between group differences. So we can say that for MIP there is already a positive trend of improvement. A statistical significance difference between group has been achieved for the tidal volumes, so the volumes that for every session patients are able to realize, to mobilize. And as you can see, even by the numbers for the double intervention group, patients in this group were able to mobilize bigger volumes than the single intervention group. Another statistical difference has been reached for the forced vital capacity as a difference between group and also as an intra-group difference. By the download of the data, we were able to calculate the work of breathing, the variation of the work of breathing calculated doing a difference between the last and the first session, and the same goes for the load and for the inspiratory tidal volume. For the first graph, here you can see that the double intervention group could realize a much bigger work of breathing, even though there is there's a slight statistical significant difference. The same can be said for the variation of tidal volume. Again, the double intervention group, as I said before, mobilized bigger volume than the single intervention group, and in this case we have a statistically significant difference. Regarding the load progression, as per protocol, patients follow the same progression, so we expected no difference, and the graph confirms this hypothesis. So, today we are asking ourselves a very important question, that is, how is it possible that the single intervention group achieved an improvement on FVC, so forced vital capacity, and not the double intervention group? Some hypotheses that we thought are that the double intervention group maybe went under longer working times, possibly overloading the patients and then causing them fatigue and respiratory distress. And also that maybe the double intervention group performed worse than the single intervention alone, because Group A did also the combo with air stacking. As Rosario said, air stacking has the capability, among many other results and properties specific of this strategy to reduce the elastic resistance of the respiratory system, so improving its compliance. And maybe with this combo, patient needed higher load for IMT. And for this reason, we think that for the double intervention group, we underestimated the training loads. It still needs to be confirmed. So, what are the take-home messages? That in this case, there has been a huge teamwork between patients and respective respiratory physiotherapists. To date, so far, this is the first study that allowed the clinicians to know the mobilized, my mistake. To know the mobilized volumes and the load progression, and this allowed us to calculate the work of breathing. This is the first study, as I said, and for this reason we think that our results can be considered valid for future studies. And we are also doing statistical analysis to understand if inspiratory capacity data are useful, and also particularly if they are statistically significant other than clinically relevant. So thank you very much. We would like to thank IGLICO, so the Italian Association of Glycogenosis, AMDA, and all our teamwork to give us the possibility to be here. So thank you very much.
Thank you very much for this nice presentation.